We conducted this study because two reasons. Firstly, that there is a growing understanding now that the gastrointestinal microbiome plays a critical role in health and disease in many conditions, especially conditions such as ulcerative colitis and Crohn's disease. Also, on top of that, there is a lot of patient interest in exploring microbially derived therapies such as fecal microbiota transplantation for these conditions. So for those reasons, we thought that this was a study that needed to be conducted to help provide some more clarity in this area. The patients that we recruited were individuals who had ulcerative colitis. They had to have active disease. We used a standardized scoring system called the Mayo scoring system, and they had to have a disease severity of 4 to 10 on that. Basically, these patients could have any disease extent except from isolated proctitis of less than 5 centimeters. And with regards to these patients, the majority of these patients had trialed and failed numerous prior medication therapies for ulcerative colitis. Now, our intervention was it was a double-blind controlled trial in assessing intensive fecal microbiota transplantation. So patients were randomized in a double-blind, one-to-one manner to either FMT or to placebo therapy, and that was done for 8 weeks. The first infusion was given at the time of a colonoscopy into the cecum, with the subsequent infusions as self-administered enemas. Patients who were randomized to placebo were then given the opportunity for 8 weeks of open-label FMT. So every patient recruited into the trial eventually had the opportunity to have FMT therapy. So we used the infusions that we used, the FMT infusions were 150 mils in volume. They were mixed multi-donor infusions, so basically each infusion was derived from 3 to 7 healthy donors, and the fecal material was combined and then utilized in those infusions. Each patient received all of their infusions from a fixed donor batch. That's a bit unique. Most studies have used a single donor approach. We used the multi-donor approach for a couple of reasons. Firstly, logistics. This study involved 80 patients, all of whom had the opportunity to receive 40 infusions. So if you do the math, it's 3,200 fecal infusions we need to produce. So no single donor is, it's impossible to conduct this study using single donors and have patients receive standardized material throughout the trial. So that's one of the reasons we used it. The second reason we used the multi-donor approach is because there has been a lot of speculation, and some prior studies have suggested that there is donor-specific effects and that there can be either good donors or bad donors that might influence outcomes. And what we wanted to do is try and minimize that, to just try and firstly assess, does FMT work or not? And so we used that multi-donor approach to try and minimize that. So our primary endpoint that we were assessing was clinical remission and endoscopic remission or response. So in layman's terms, whether patients' symptoms had resolved, and whether when we looked with the endoscope they had healing or significant improvement in their bowel wall appearance. And we found that in the blinded section of the trial, 27% of patients in the FMT arm met this primary endpoint, as opposed to 8% of the placebo arm, which is a threefold difference, which was statistically significant. And we had secondary clinical outcomes and endoscopic outcomes that were also evaluated. So this study had 81 patients, so it's a little bit hard to do too much in terms of post hoc analyses. What we did find is that patients, regardless of the extent of disease, seemed to all benefit. So even patients who had what we call pancolitis, where their entire large bowel was affected, despite the fact that our therapy was predominantly enema-based, they still had a significant improvement relative to placebo with FMT. What we did find, however, is that the patients with the very most severe end of the spectrum, the patients who had what we call Mayo 3 endoscopic disease, they did not appear to benefit as well. They did not appear to benefit from the FMT treatment in our trial. Remember, our study Especially when it comes to post-hoc analyses, these numbers are relatively small, but we could not find a significant difference on those analyses. It was more the fact that patients who are on corticosteroids, we employed a very fixed steroid wean, where patients who'd even been on steroids for weeks or months or years, had to wean completely off steroids during the 8-week trial. And so this is a very demanding part of the trial that patients often weren't able to tolerate. I think the take-home message for clinicians is that FMT therapy is very promising in ulcerative colitis. I think that, we're going to have to refine things a little bit further. This isn't Clostridium difficile infection where you're going to get your 90% cure rates, and that regardless of donor you're going to have very comparable benefits. I think ulcerative colitis is a different beast. It's a multifactorial condition involving genetic, environmental, microbiological factors that all have a complex interplay to lead to disease. And so we're going to have to be smarter in how we go about treating it. I think in the field moving forward, what we're really interested in looking at is the microbiological studies that we've got planned on the samples collected for this, associated with this trial, and also trying to match donors and patients, because I think that's probably where the field is going to move to, is trying to tailor microbial therapy based on individual patients. In the long term, the ultimate aim would be to hopefully one day be able to use defined microbial consortia and use that specific to individual patients to treat their condition.